Okay, let's get started. Um, Good morning, everyone. Thank you for joining us for Asthma Grand Rounds today. We really have the pleasure of having Dinah Foer, who's a member of the Division of Allergy and Clinical Immunology and General Internal Medicine here at the Brigham, and she's going to be talking about diabetes, metabolic dysregulation, and asthma. Just to remind you, this is a live webcasting. You can submit a question to our speaker by entering it into the chat. And at the end of Dinah's talk, we'll address those questions. I think we'll have a great talk. For CME credit, please email your name and your degree to eIsrael Israel Assistant at bwh.harvard.edu so we can enter in your CME credits. If you have any technical problems during the live broadcasting, send an email to BWH Webcast Troubleshooting. So that's all one word, BWH Webcast Troubleshooting at partners.org. I wanted to remind you about the upcoming fantastic group of lectures that we have scheduled for you. So in September, we're going to have Exploring the Genetic Basis of Asthma by Quan Liu. In November, we're going to have Mast Cells in Asthma, More Complicated Than We Thought by Josh Boyce. In January of 2025, we're going to have a talk on airway smooth muscle pathobiology and asthma exacerbations by Ramaswamy Krishnan. And in March, we're going to have a talk about the role of viruses in asthma development and severity. And lastly, in June, we're going to have an update on pulmonary function test interpretation, which has really changed a lot in the last few years by Nancy Lang-Vaidya and Barry Shea. So without further ado, let me turn this over to Dinah, who's an up-and-coming star in the Division of Allergy and Immunology, and she's going to be talking about diabetes, metabolic dysregulation, and asthma. Dinah, we're really looking forward to your talk. I'm going to stop sharing.
Okay, I'm going to start sharing. All right, how does that look to you, Elliot?
Looks good.
Okay. Well, thank you for the introduction and good morning, everyone. It's really an honor to be speaking today at Asthma Grand Rounds, and especially so on a topic that I think is going to be really important in transforming our asthma care for years to come. So although all of us probably like to think that asthma is the most important disease, type 2 diabetes, which I'll be referring to simply as diabetes for the rest of the talk, is actually the fastest growing chronic disease in the US. 20 years ago, prevalence was around 6%, and today it is 11% and climbing. And looking at these heat maps, there are clear geographical disparities. So prevalence estimates for 2021 ranged from about 6.5% in Colorado to 14.4% in Puerto Rico. And when you look at rates by race and sex, all subgroups are going to experience a rate increase, but the magnitude of the increase is going to vary. So the rate in women is rising more than men, and Black women will continue to have the highest rate of disease. And these trends should give us pause, and I think on a number of levels, and really begs the very basic question, how are these trends going to impact our patients with asthma? So we can start off by looking at what preclinical models tell us about the links between diabetes and the lung. In this study, investigators used an insulin-induced hyperinsulinemia murine model that has multiple other features of metabolic dysregulation, such as glucose intolerance and increased serum triglyceride levels. So higher insulin levels increased lung collagen, and that's in red, and led to an increase in smooth muscle cell proliferation in pink, without a significant increase in mucin content, which is in purple. So functionally, these hyperinsulinemic mice demonstrated increased airway hyperreactivity to a methacholine challenge compared to control. Insulin-induced changes in human airway smooth muscle cells that were isolated from surgical lung samples were also examined. And by 72 hours of insulin treatment, there was about an 8-fold increase in airway smooth muscle cell number. And the treated cells also showed deposition of collagen 1, which is involved in airway remodeling. Insulin's ability to potentiate airway hyperresponsiveness has also been shown in studies that test the role of insulin on airway parasympathetic nerve stimulation. Here, investigators compared a polygenic rat model of diet-induced obesity to obesity-resistant rats to examine the effect of insulin on airway parasympathetic nerves and resulting airway contraction. So in figure A, vagal nerve stimulation induced bronchoconstriction in the obese mice, represented by the black circles, and reducing insulin with streptozotocin. So there, significantly reduced that bronchoconstriction. When insulin was restored acutely or chronically, that blocked the streptozotocin's effect. So in contrast, the obesity-resistant rats had lower baseline bronchoconstriction to nerve stimulation, and reducing insulin had no impact on bronchoconstriction. Actually, to the contrary, supplementing the insulin either acutely or chronically significantly potentiated bronchoconstriction. So taken together, these results suggest that insulin potentiates pathways that lead to vagally induced bronchoconstriction independent of obesity. Diabetic and non-diabetic patients with hyperglycemia have been previously shown to have increased glucose in their airway secretions, but the effects of chronic glucose exposure in the airway secretions is unclear. In this study, normal segmental bronchi from non-diabetic patients were used to test the effects of high glucose treatment on responsiveness to contractile agents as measured by electrical field stimulation. Hyperglycemia enhanced the bronchi's responsiveness, and you can see here that that effect peaked at 2 hours and lasted through the end of the experiment. The hyperosmolality control, which was mannitol, did not produce any variation. Interestingly, acutely normalizing the glucose by washing was ineffective in reversing the hyperresponsiveness, suggesting that other pathways that are induced by a high glucose environment may drive prolonged effects in the airways. Of note, though, hyperinsulinemia was not assessed in the study, so it remains unclear if this glucose effect is truly independent of insulin levels. And numerous other studies have associated hyperinsulinemia or insulin resistance, hyperglycemia, with mechanisms that are relevant to asthma. And I listed a number here, but these include glycosylation of chest wall and bronchial tree proteins, thickening of the basal lamina, induction of oxidative stress pathways, and susceptibility to respiratory infections. So likely there are multiple mechanisms at play, but obviously not everyone with diabetes has asthma. So how these mechanisms interact and drive an impact on asthma incidence and clinical outcomes in humans remains unclear. So that brings us to the clinical realm and what we know about the relationship between diabetes and asthma outcomes. So one way to measure the severity of insulin resistance in humans is the HOMA-IR, which is calculated by multiplying fasting insulin by fasting glucose divided by a constant. And we'll see this measure throughout this talk because it's a convenient way to test the association of insulin resistance on outcomes. This study was a population-based prospective study that investigated the effects of lifestyle interventions on cardiometabolic disease in Denmark that also captured insulin asthma symptoms such as wheeze and shortness of breath. Insulin resistance was defined as HOMA-IR in the upper quartile of the non-diabetic population at baseline. So as you can see here, compared to participants who were not insulin resistant, patients with insulin resistance or diabetes had higher risk of wheeze and shortness of breath. And these associations remain significant after accounting for different measures of adiposity, such as waist circumference or waist-hip ratio, and also within subgroup analyses of just overweight and obese participants. And even within the group of healthy weight participants, insulin resistance was associated with increased incidence of wheeze and other symptoms, suggesting that the incident symptoms were not driven by comorbid obesity. Consistent with those findings, a population-based prospective cohort study in Norway found that metabolic dysregulation increased the odds of an incident asthma diagnosis among patients who were asthma-free and asthma symptom-free at baseline. So after accounting for the other metabolic factors that they looked at, including high cholesterol, triglycerides, weight circumference, and hypertension, diabetes was the strongest risk factor for an incident asthma diagnosis. So what about the relationship between diabetes control and asthma outcomes in patients who already have asthma? This table is from a study analyzing the association between hemoglobin A1C levels and asthma-related hospitalizations in the UK Biobank. And the authors identified that hospitalization risk increased continuously with elevations in hemoglobin A1C, independent of obesity. They also found that patients with prediabetes, so that's about 1 in 3 people in the United States, had a 1.7 increased odds of an asthma hospitalization, independent of obesity. In another study, this one done in an administrative US claims database, researchers found that patients with hemoglobin A1C values in the prediabetes and diabetes ranges had significantly higher risk of asthma exacerbations, which again strongly suggests that glycemic dysfunction itself might be a driver of worse asthma outcomes. And the relationship between diabetes and exacerbations is particularly relevant in severe asthma. The data that I'm going to show in the next few slides come from the Severe Asthma Research Program, or SARP, where in this study, they grouped patients based on exacerbation frequency into 3 buckets. So exacerbation-prone asthma, exacerbation-intermittent asthma, and exacerbation-resistant asthma. And they found that among the characteristics distinguishing exacerbation-prone asthma from the other types were diabetes, high BMI, and hypertension, pointing again to metabolic dysfunction as a key risk factor for exacerbation susceptibility in severe asthma. So in SARP, insulin resistance also predicts lung function decline. And here, patients were grouped by degree of insulin resistance, with the blue line representing no insulin resistance, the yellow moderate insulin resistance, and the red high insulin resistance. And you can see lung function, which is depicted by bronchodilator FEV1 and FVC on the y-axis, is lower with increasing insulin resistance. And then the authors, in a really elegant sub-analysis, tried to account for potential confounding by obesity, especially on the chest wall. So they separately analyzed patients with severe obesity. And again, they saw the same pattern, that lung function is lower with increasing insulin resistance. And while not shown here, the decline is also faster in those with higher insulin resistance. If we just take a moment to zoom in on the characteristics of the patients with insulin resistance in that study, we see that 140 patients in the cohort had moderate or severe insulin resistance. Yet if you look at the red box, only a small percentage of those patients had a history of a diabetes diagnosis, and even fewer of those were taking medications for diabetes. And to me, this suggests that there may be a significant missed opportunity to intervene on an asthma risk factor by identifying and treating insulin resistance. And finally, severe asthma patients with higher muscle adiposity, as measured by paraspinous muscle density, or PSMD, have lower lung function over time. So at baseline, women and men with asthma had lower baseline muscle density compared with non-asthma participants. And over the 5-year study period, PSMD predicted lung function decline only in women, though, after accounting for age, eosinophils, oral corticosteroid use, exacerbations, and BMI. So for women, as you can see here, as muscle density declines and adiposity increases, the FEV1% predicted drops, with the strongest correlation among women in the lowest tertile of density. And if we think about it, muscle is the largest source of insulin-sensitive tissue in the body and also the primary site for insulin-mediated glucose uptake. So this study suggests that PSMD might be able to be used as a tissue-level biomarker of the relationship between systemic metabolic dysfunction and asthma clinical outcomes, at least in women. And I think the skeletal muscle adiposity study really highlights just how interrelated diabetes and obesity are together. And while I've tried to present studies so far that account for concurrent obesity to be able to hone in on the metabolic effects that might be independent of obesity, it's really very challenging to fully separate these two entities. So we know that people with obesity are at least 3 times as likely to develop diabetes compared to those without obesity. And about 90% of patients with diabetes have overweight or obesity, which is nicely reflected in this heat map with the darker colors representing comorbidity. But we also know that diabetes is widespread and can exist without overt diabetes. And I wanted to briefly touch on obesity and asthma so that we can better acknowledge potential confounders in our study. CDC data here demonstrate that adults with obesity, represented by the green bars, have a higher prevalence of asthma compared to adults with healthy weight or overweight. And this is particularly true for women. Data from SARP also show that asthma severity is increased among adults with obesity, independent of age of asthma onset. And among patients with severe asthma, 60% or more have comorbid obesity. While obese asthma is often referred to as a single phenotype, in reality, there are likely several phenotypes of obese asthma, some of which are depicted here. So asthma in patients who later developed obesity, asthma newly arising in patients with prior obesity, etc. And this framework is similar to the way that we think about obesity itself, that there are actually multiple obesities. So people with diabetes or other metabolic comorbidities typically have android, or these apple-shaped bodies, meaning that they have larger waists and carry a lot of weight around their abdomens. Gynoid or pear-shaped bodies, so carrying more weight around the hips with a narrower waist, has different implications for metabolic abnormalities and risk factors of disease, and perhaps also so for asthma. And heterogeneity becomes particularly important when we start to think about the endotypes underlying the observed asthma phenotypes. And generally, there's a perception that obese asthma is a T2 low disease, but we need to be careful to understand where those data are coming from and keep this potential for heterogeneity in mind. And the risk for overgeneralization of what BMI means for an asthma phenotype, I think, is nicely shown by looking at the biologics trial literature. So when we looked at 16 pivotal trials of asthma biologics, all of which have the greatest benefit in T2 high patients and represent a moderate to severe asthma population, the patients are not lean. So the mean BMI for placebo and treatment groups is solidly overweight, and several study populations veer explicitly into obesity territory. So again, the perception that obese asthma is a T2 low disease may be more nuanced, requiring additional understanding and endotyping. So in that vein, SARP investigators identified that increased plasma IL-6 is associated with metabolic dysfunction and more severe asthma. This was true in patients with and without obesity, shown in figure B, though the proportion of asthma patients with high plasma IL-6 levels was much higher in obesity. A history of diabetes, seen in figure C here, was significantly more common in IL-6 high than in IL-6 low asthma. Plasma IL-6 predicted an increased risk of asthma exacerbations, including, as shown in this box, in patients without recent systemic steroid exposure, suggesting that at least steroid-induced systemic metabolic inflammation was not predominantly driving this association. Zooming in again on the patients with metabolic dysregulation, the patients that had the highest HOMA-IR had higher IL-6, but lower blood and sputum eosinophils and higher sputum neutrophils compared to groups with moderate or without insulin resistance. And this would seem to suggest that metabolic asthma might be T2 low. But the group with moderate insulin resistance appears to have higher blood eosinophils, higher sputum eosinophils, and lower sputum neutrophils than the group without insulin resistance, pointing to the possibility of multiple endotypes in this metabolic asthma population. And finally, this table is from a cross-sectional population-based study in Denmark that included asthma of all severities, in contrast to the severe asthma population above. And this group found that insulin resistance was associated with a higher risk of allergic asthma, but not with non-allergic asthma, as defined by the presence of asthma and positive aeroallergen, IgE. And so overall, I think these data tell us that there is still much for us to understand about the links between insulin resistance, obesity, atopy, and asthma, and elucidating these connections has implications for how we can best manage this population. Which brings us now to how the presence of diabetes might impact asthma management. So looking to the GINA guidelines, diabetes is mentioned, but only in the context of adverse effects of steroids. There are no mentions of insulin resistance or glycemia driving the risks of exacerbations and hospitalizations, and no guidance on management for this at-risk population. And not to make it a competition, but the COPD guidelines do explicitly include a section on metabolic comorbidities and call out diabetes specifically, acknowledging the risks on COPD outcomes. In contrast to the lack of strategies in the asthma guidelines, the primary literature suggests that patients with diabetes may have decreased response to common medications used to treat asthma. This paper used machine learning approaches on a data set from SARP to identify clusters of patients based on response to intramuscular triamcinolone. Cluster 4, circled here, was a group characterized by patients who were young, had diabetes or obesity, were female, and very symptomatic. After triamcinolone injection, cluster 4 patients were still worse off compared to the other clusters, with almost no change in lung function and even a small decrease in maximal post-bronchodilator lung function. Looking at insulin resistance specifically, severe asthma patients with higher insulin resistance in red have lower FEV1 responses to beta-adrenergic agonists and systemic corticosteroids. In this figure, the dashed red line is the median value in participants without insulin resistance. So you can see that patients with high insulin resistance have a blunted response that's evidenced by maximal bronchodilator reversibility testing that was performed at both baseline and follow-up visits. FEV1 response to systemic triamcinolone testing was also lower in those with both moderate and severe insulin resistance compared to participants without insulin resistance. And in this study, the insulin-resistant participants had low sputum eosinophil percentages, which is already known to predict albuterol and steroid responses in this cohort, and also to classify the presence of type 2 airway inflammation. So to me, these results raise the question that if we treat the insulin resistance, could we improve disease control and even potentially their responsiveness to T2-directed treatments? In determining T2-ness and managing asthma, we increasingly rely on biomarkers and biomarker cutoffs to select treatments. And no studies have looked at biomarker cutoffs specifically in diabetes populations, but this study showed that with increasing BMI, as shown by the red and the green lines, there's an overall decreased ability of our commonly used biomarkers, so that's FeNO, IgE, blood eosinophils, to predict high sputum eosinophils. In fact, none of those markers significantly predicted high sputum eosinophils in patients with obesity. And the authors of this paper then calculated new cut points, so the maximal sensitivity and specificity for patients with obesity. And they suggested that lower cutoffs for these 3 markers were needed for patients with obesity than used for other groups. And given the importance of these markers as clinically accessible surrogates for sputum eosinophils, this should make us wonder if we're misclassifying patients with obesity, again, also with likely diabetes, as having or not having eosinophilic inflammation, and what that means for their care. Biomarker qualification is really particularly relevant in the context of biologics. And when we looked at those 16 pivotal biologics trials, we found that only 3 mentioned diabetes, and none recorded diabetes as part of the demographics or the classic table 1. 2 mentioned diabetes in the exclusion criteria, and 1 mentioned it in adverse effect reporting. So again, this really limits the information available to us to guide management for this high-risk population. Spirometry is a common tool in asthma management and has been looked at in a number of longitudinal studies of patients with diabetes, though it's important to know that most of those populations did not have comorbid asthma. And the primary finding from these studies is that type 2 diabetes is associated with a lower FVC, but a largely preserved FEV1 FVC ratio that's independent of sex and smoking history and BMI. The degree of impairment, though, varies across studies and is often quite small. And in most of the studies, alternate causes of these very small differences in FVC were not evaluated, I think making this finding somewhat nonspecific. So far, there are no studies looking at what happens to asthma exacerbations or spirometry in asthma patients if glycemia improves. But there was this study from several years ago. I like the title. It was called the Sweet Breath Study that looked at this question with regards to lung function in, again, patients without asthma. So this was a prospective interventional study, 60 patients with type 2 diabetes without a medical history of lung disease, but they did require that the patients had an FEV1 that was less of 90% predicted. The patients were initiating type 2 diabetes treatment with a variety of oral or injectable drugs, and spirometry was done at baseline and after a 3-month period, at which point the authors assessed response to therapy. So the patients with a hemoglobin A1C reduction of about 0.5% were considered to be good responders, and those without that degree of improvement were termed non-responders. And what the analysis showed was that the good responders also experienced a 6.4% increase in their FEV1 after the 3-month period of treatment, but that this correlation was not true for FVC. They also showed that the absolute change in hemoglobin A1C, but not the other potential confounders like age, sex, type 2 diabetes duration, smoking, absolute change in BMI, independently predicted the subsequent change in FEV1. So far we've been thinking about why diabetes matters for our patients with asthma. And I just wanted to flip the frame to think about why and how we might be able to demonstrate to our colleagues in endocrinology or primary care that asthma matters to their patients with diabetes, since ultimately most asthma is cared for outside of our allergy or pulmonary specialty clinics. And the reason I think this question is well-timed is because there's already a paradigm in the diabetes world that comorbidities in other organs directly influence diabetes treatment selection. So this includes the heart, the liver, the eye, adipose tissue, vasculature, and extends to numerous psychosocial and socioeconomic domains that are depicted here. The complete absence of respiratory disease on the schema, I think, highlights an opportunity to think about how the lung might be integrated to inform diabetes treatment choice. And one starting point is to understand how diabetes treatments impact asthma. We know already that obesity negatively impacts asthma outcomes, and several diabetes medications are, perhaps counterintuitively, weight promoting. So insulin, sulfonylureas, and TZDs. Metformin and DPP-4 inhibitors are weight neutral, while SGLT2 inhibitors and GLP-1 receptor agonists or GLP-1RAs promote weight loss. And so it's worth it to understand how these medications impact asthma outcomes. Metformin, which is traditionally a first-line medication for patients with diabetes and prediabetes, has been associated with a decreased risk of asthma exacerbations compared to patients not using metformin. This figure here shows the cumulative incidence estimates of asthma exacerbations among metformin users versus propensity score matched non-users in a US claims database. However, this study and others like it, there was one from Taiwan as well, were initially limited by an inability to measure critical confounders such as concurrent glycemic control, BMI, smoking, and race. So to address those limitations, one of the groups then looked at metformin use and asthma exacerbations in an electronic health record-based cohort of individuals with comorbid asthma and diabetes. And in the electronic health record, they could capture more patient-level characteristics to include in the modeling. And after including those variables, they found that metformin was still associated with a lower hazard of asthma-related ED visits and hospitalizations. Metformin is not directly comparable to other diabetes drugs. It's often started earlier or for pre-diabetes. So what about other therapies that are used for new onset or poorly controlled diabetes? Initially in preclinical models, TZDs had shown potential benefits in the airway, and those data led to a series of clinical trials of these drugs in patients with asthma. However, not only were there no asthma-specific benefits, but there were other risks, and at least one trial was stopped early. Insulin has also been linked to worse pulmonary function and incident asthma, and that's consistent with the preclinical studies that we saw earlier. A tangent in insulin technology had insulin being inhaled rather than injected. And in both inhaled and injected forms, insulin appeared to worsen pulmonary outcomes, though the FEV1 FEC ratio and DLCO, as you can see here, decreased more in the inhaled insulin group. Moving now to DPP-4 inhibitors. DPP-4's inhibitors have low hypoglycemia risk, neutral weight impact, and are generally well tolerated. Again, preclinical research models that looked at airway inflammation with DPP-4 inhibitor use had conflicting results, with some models showing decreased inflammation via downregulation of eotaxin and RANTES, while others found a detrimental effect in allergic models of asthma. And those data led to a retrospective observational matched cohort study using administrative claims data of patients that were initiating a DPP-4 inhibitor or non-DPP-4 inhibitor medication. Patients were then followed for asthma-related outcomes for 12 months that were summarized in these three measures: risk domain asthma control, overall asthma control, and treatment stability. And these measures, they're pretty nondescript, but they included things like asthma hospitalizations, OCS prescriptions, SABA use, and ED visits. And as you can see, the study found no significant benefit from DPP-4 inhibitor compared to non-DPP-4 inhibitor medications. And around this time, groups also started to look at GLP-1 receptor agonists, a class of medications that acted in a shared pathway with DPP-4 inhibitors, but have differing effects on weight, glucose, and cardiovascular outcomes. So just to look at the mechanisms for a minute, DPP-4 inhibitors block the breakdown of GLP-1 and GIP, that's also known as glucose-dependent insulin-tropic polypeptide, to increase the levels of the endogenous active hormones. In contrast, GLP-1 receptor agonists are peptide derivatives of either exendin-4 or human GLP-1 that are designed to resist the activity of DPP-4, and therefore they have a prolonged half-life. Endogenous GLP-1 levels are extremely low in comparison with exogenous GLP-1, and GLP-1 receptor agonists have been shown to increase GLP-1 hormone levels by at least tenfold, which explains, at least in part, the increased potency that's seen with GLP-1 receptor agonists compared to DPP-4 inhibitors in the cardiometabolic domain. About 5 years ago, the People's Lab at Vanderbilt demonstrated that signaling in the GLP-1 pathway might impact airway inflammation via regulation of IL-33 release. And in this JACI paper, they used an alternaria challenge model of asthma to demonstrate that the GLP-1 receptor agonists decreased lung inflammation, so as shown here by staining for perivascular eosinophils in figure B and mucus in figure D, with a decrease in IL-33 release and numerous downstream cytokines, and a corresponding decrease in airway hyperreactivity shown by the blue line. Since those studies were done in BALP/C or lean mice, they later used a polygenic model of obesity that was characterized by hyperglycemia, hyperinsulinemia, and hyperlipidemia, and the corresponding lean genetic control mouse to look again at the effect of GLP-1 receptor agonist signaling on IL-33 and TSLP-induced airway inflammatory responses. And in that study, they recapitulated many of the findings in their prior study, including that GLP-1 receptor agonists inhibited IL-33 and TSLP release into the airway, lung ILC2 number, responsiveness to methacholine, et cetera. But they also showed that the GLP-1 receptor agonist treatment, but not anti-TSLP or anti-SD2 therapy, had an inhibitory effect on allergen-induced neutrophilia and neutrophil chemoattractants. Since then, a number of groups have been working on the mechanisms of how this drug class might benefit airway inflammation in human asthma. Several years ago, our group was the first to show that among patients with asthma and diabetes, those initiating treatment of the GLP-1 receptor agonist for diabetes had fewer asthma exacerbations at 6 months compared to patients initiating other diabetes treatments. This was also true when we looked at cardinal asthma symptoms such as wheeze, and these benefits seemed robust even after accounting for weight change and glycemic improvement while on treatment. And these have since been confirmed in other retrospective analyses looking at asthma outcomes in GLP-1 receptor agonist users. We've also used MGB biobank samples to identify potential biomarkers in prevalent GLP-1 receptor agonist and non-GLP-1 receptor agonist treated patients with both diabetes and asthma. We found in one study that among all biomarkers explored, only periostin was significantly different between groups. Since this was a small cohort of prevalent diabetes treatment users, we then validated this in a non-asthma cohort from a randomized controlled trial of GLP-1 receptor agonists in obesity. So using those RCT samples, that allowed us to ascertain that the decrement in periostin was not due to weight loss or glycemic improvement. As you can see here, periostin decreased in GLP-1 receptor agonist treated patients, but not in the DPP-4 inhibitor or the diet-treated patients. And this supported an effect independent of changes in glucose control and weight. In collaboration with the Boyce Lab, we've used their IL-33 dependent AERD mouse model in which mice are primed with dust mite and respond to lysine aspirin with increased airway resistance. You can see here in figure B that after challenging the mice with aspirin, lung resistance increased relative to baseline. But this effect is inhibited by a single dose of GLP-1 receptor agonist that was administered 24 hours before aspirin challenge. And the extent of inhibition was comparable to the effects of IL-33 or ST2 blockade. And I had gotten ahead of myself for a second there, but the lung lysate from these mice showed decreased levels of IL-33 and downstream targets of IL-33 in the model. And I've lingered on this class of drugs in part because several medications in the class are now independently approved for obesity management, vastly expanding the eligible population and consequently the number of our asthma patients who are using or will be using these drugs. And these drugs are the first in a robust pipeline that are comparable to bariatric surgery in terms of total % body weight change, which may help our patients reach the 10% total body weight loss goal that are recommended currently by asthma guidelines. Prior to these drugs, the impact of weight loss on asthma had primarily been through diet and surgical interventions. And in those studies, losses of 10% total body weight or more reduced asthma symptoms, decreased rescue inhaler use, and improved quality of life among patients with asthma. And as an example, in this study of more than 2,200 patients with asthma who had bariatric surgery, exacerbations decreased post-surgery and asthma symptom scores improved. But for our patients with diabetes, one of the caveats to bariatric surgery is that they may be less likely to benefit from the associated weight loss, presumably because the weight loss doesn't fix all the other drivers of poor asthma control, such as insulin resistance. In this longitudinal studies of about 500 or 555 patients with asthma who received bariatric surgery, having metabolic dysregulation limited the long-term improvement in asthma control test scores post-surgery, again, independent of weight loss, supporting the need for novel medical approaches. And while we might have some hints as to how GLP-1 receptor agonists may benefit patients with asthma, the precise mechanisms are truly still unknown. And some of these questions will be answered by the GATA-3 trial that's being run at Vanderbilt currently, which is a single-site 24-week RCT that's using semaglutide in adults with poorly controlled asthma and obesity, but not with diabetes. A similarly designed trial focusing on metformin in adults with obesity and asthma will also start recruiting. And while both these trials exclude patients with diabetes explicitly, the findings could be used to parse effects related to weight loss or obesity-induced inflammation on the airways. To date, there has only been one randomized controlled trial of liraglutide, which is a GLP-1 receptor agonist, that looked at pulmonary function as the primary outcome, but this was not done in a population with asthma. So the study population had diabetes and no diagnosed asthma or COPD or other lung disease. But again, the patients were required to have a baseline reduction in FEV1 10% or greater of the predicted value. They didn't really go into more details as to what or why they chose that. And the 7-week study's primary outcome was an increase in FEV1 by at least 20%, so a very, very high bar. And as you may expect, the primary outcome was not met, so no difference in FEV1, but they did detect an increase in FVC by about 5.4%. They examined a single biomarker, serum surfactant protein D, that they argued was a very indirect measure of alveolar capillary barrier integrity. So to better characterize the potential benefits on pulmonary function, but also on a range of other asthma-related outcomes and biomarkers in patients with both asthma and diabetes, we've been running an MGB-wide prospective cohort study in which we recruit patients with asthma and type 2 diabetes, receiving GLP-1 receptor agonists in routine endocrinology and primary care. And we measure spirometry, ACQ, FeNO, and collect biological samples from the blood and in the nose at baseline, 3-month, and 6-month intervals to assess with in-person change. And many of our measures are synced with the GATA-3 trial, so we'll be able to leverage both of these studies to assess differences in asthma phenotypes, obesity, diabetes, and asthma-specific metrics that might yield new insights as to the mechanisms of these drugs on airway inflammation. So to summarize the challenges that are facing clinicians and research gaps for investigators, diabetes remains both an under-recognized risk factor for asthma, and guidelines in both pulmonary and endocrinology domains are silent. And this matters because our patients with asthma and metabolic dysregulation are stuck in a vicious cycle. We've now seen that these patients have higher risk for poor outcomes, hospitalizations, exacerbations, decreased lung function over time, and that they have poor response to asthma controller medications and other interventions like bariatric surgery. Biologics are available, but again, patients with diabetes are not specified in these trials, and the biomarkers and thresholds that qualify patients and track response to treatment in conventional care may not be the same for this population. More exacerbations translates to more oral steroid prescriptions, which still, despite the biologics, are our only treatment for exacerbations. And this, of course, worsens glycemic control and increases weight gain, perpetuating this cycle. Certainly, we can always refer these patients to our colleagues in endocrinology and weight management or nutrition, much like we do with GI for GERD or ENT for sinus care in our asthma patients. But many of these clinics are already saturated with non-asthma patients, and they may not have the bandwidth, at least yet, to consider another organ system in their diabetes management. So in the meantime, we may be already be able to make some small changes in our clinical care for these patients that reduce risk and promote improved metabolic health while we wait for the guidelines to catch up. So research will hopefully answer the many remaining open questions, and I've just listed a few here. So should we be monitoring A1C or HOMA-IR in certain patients like severe asthma patients? Should endocrinologists be ordering PFTs? I think Elliot does not want that to happen. Should clinical trials use different biomarker cutoffs? Should we be preferencing use of certain diabetes medications in comorbid asthma, et cetera? So I started with the question as to why, in the context of rising prevalence, diabetes matters for asthma. And with a whole new generation of patients with diabetes on the horizon, I'm hopeful that with interdisciplinary attention, we can identify interventions that meaningfully and equitably benefit our patients with asthma. So I just wanted to thank everyone on Zoom for listening, and Elliot, Nora, and Chris for their leadership of the MGB Asthma Center and the generous invitation to speak today. And I don't know if I was intentionally assigned to this date, but today happens to be National Donut Day, which dovetails very nicely with the theme of my talk. So thank you for that. And I also just wanted to thank my mentors, Joshua Boyce, Elizabeth Carlson, and Katie Cahill, and to acknowledge that the GLP-1 receptor agonist work that I've done is really all rooted in an idea that Katie had years ago that she generously shared with me, and it's been a privilege to work with her since then. And I wanted to thank my mentors in endocrinology, Vanita Arota, Deborah Wexler, Marie McDonald, and in primary care, especially David Bates, our collaborators and funding sources. And I'm happy to take any questions.
Dinah, Dinah, that was a wonderful talk. Can you hear me?
I can hear you.
Good. Okay. That was a wonderful talk. And so there are several questions in the chat, and I would encourage anybody else who's on to put questions in the chat that Dinah can answer. So the first question is, does insulin therapy impact lung function in patients with type 1 diabetes?
So I don't know anything about type 1 diabetes. So not a question I can answer, and I'm sorry about that, but I can look into that for you and get back to you.
Okay. And the second question is, do inhaled steroids impact HOMA-IR?
I don't know if that has been looked at directly. So again, that is something that I can look into, but I think when I've looked before, I didn't find anything concrete. But that's a terrific question.
Okay. And a question that I had in relationship to the first set of slides that you showed about the effects of insulin on lung and lung function and lung fibrosis in these models. And maybe this is a kind of me being a little bit antediluvian, but I always thought of diabetes as a insulin poor disease where people aren't producing enough insulin. And so how do we relate that to all the data that you showed about high insulins? And I understand that there may be a subset of patients, but aren't most type 2 diabetics insulinopenic?
No.
Okay.
So it's a great question. And there's definitely, and I think that also goes to the type 1 diabetes versus type 2, but in many patients, what's happening is that they are insulin resistant. So even if they have a lot of insulin at first, I mean, eventually the pancreas burns out and you're right. And then there's not any insulin. And that's, I think, much later stage. But for many patients in the interim, they have a lot of insulin, but they're not able to use the insulin to take in the glucose. So they're sort of bathed in both insulin and glucose. And so that's why those hyperinsulinemic models are still instructive. Again, not to everyone, especially later stage disease, but certainly for a good portion of patients with active diabetes.
Okay, great. Thanks for that clarification. And then you showed data, or I think it was around slide 29, about how reducing glycemia improved lung function. And in that study that was published, were there any controls, or was it just treating those patients and saying, hey, they get they got better because remember it was related to the degree of reduction of hemoglobin A1C, but the question is confounding by people who are more compliant or more adherent and compared to people who are not, which and that you might see those differences.
Yeah, so I think that's a great point. There was no controls not on medication. It was an interventional study, so it wasn't like, following them in usual care where we would expect more patients to probably be, non-adherent. So I think maybe we still think that maybe the patients would be taking their medication, but I agree with you. I think that there are some problems in that study. I think it's intriguing, but I think it definitely needs to be redemonstrated in a more rigorous trial environment. And frankly, I think that the likelihood that any of these drugs or moving the dial on glycemic control will have a big change on pulmonary function testing is probably asking a little bit too much. There may be other methods of looking at lung physiology like oscillometry or other things that we now know may be more relevant in patients with obesity where we can see changes, more nuanced changes than at the level of spirometry.
Okay. And lastly, so the Real Glad study that you're that you're running at the Brigham. So this is patients who are getting treated with the GLP-1 agonists, and you're following them. Is that what you're doing?
Yeah, so we're just taking advantage of routine prescribing. I mean, these drugs are so people are trying to prescribe them. Sometimes insurance or supply doesn't allow them to be prescribed, but we're trying to take advantage of just their use in routine care to capture these patients once they're prescribed at baseline before they start taking it or within like the first week or so, and then at 3 months and at 6 months of use. And at least in the data, it suggests that many patients are not adherent past like 6 or 8 months or not able to, either because of side effects or because of insurance change or supply or something like that. So that's why we have only been tracking out to 6 months at this point.
Right. There's another question in the chat about whether you're going to try to mention to measure bronchial hyperactivity in Real Glad.
Right now, because of funding and just the scope of our team, no, we're not, but that's definitely something that would be nice to do. And I would, before that, I would really like to do oscillometry, because I think that is going to be something that in the future we see maybe is impacted by insulin resistance or metabolic dysregulation. But again, we just don't have that in place yet.
Okay. There's another question in the chat about how can you separate A1C and steroid use? In other words, if poor asthma control equals steroids and higher A1C, it's hard to know whether better A1C means better control or less use of asthma medications that might make the A1C worse.
Right, and I think that that's inherent to this asthma population, particularly severe asthma. And I think we have to ask ourselves, like, how much does it really matter what's driving the A1C at this point? If we can intervene by reducing steroid use in this population and it benefits the A1C and their asthma gets better, great. So I agree, it's a little bit hard to parse outside of like a trial environment, but I don't think that should stop us from trying.
Great. Okay. I don't see if anybody has any additional questions.
I saw something in the Q&A.
Let me, okay. Yeah, I see a bunch of things in the Q&A. So will you or others in this area be able to parse out the effects of GLP-1 agonists on smooth muscle versus inflammation in your study?
In my study, so far, I don't think so, but I know other groups are looking at murine models. So again, not humans, but they've tried to look at whether the effect of these drugs is directly on the smooth muscle, because we already know that GLP-1 receptors are actually abundant in the lungs, so in the submucosal glands of the trachea, pulmonary artery smooth muscle, and type 2 pneumocytes. And I think so far, the mouse folks have not necessarily found a direct effect on the smooth muscle.
Okay, and then there's another question. For those of us doing asthma research, is it enough to just control for diabetes, or should we be asking questions about the obesity shape, pear or apple? And how would you typically ascertain this?
So that's a really important question. And I actually have a slide.
Please.
I just want to share it just about like measuring obesity and adiposity and just the different options. I'm not an obesity epidemiologist or a specialist, but I have been fortunate to learn from others about this. So I just wanted to share it briefly. And because
Sure,
I know
please.
like this question of BMI is often like in a matter of debate, like is BMI useful or not? So let me try and share this again. Okay, can you
There you
see
go.
it?
Yes, we're
Okay,
seeing
great.
it.
So, like, how do we, to next great question, like, do we control for this? What do we measure, et cetera? So I think the bottom line is that if you scroll to the bottom, like BMI is still a useful tool, even without assessing, is it gynoid or android, pear, apple? And it's a pretty good measure of individual level adiposity. So again, like where the adipose tissue falls out. And its other advantages are that it's simple and easy to calculate. But if you can, I do think that getting waist circumference, which really gets to that gynoid versus android shape, is very useful and is an excellent proxy of fat distribution. So I think that if it's possible to do that, then that's probably even better, or in addition to BMI. And that's because waist circumference has also been associated with cardiometabolic outcomes. So if you were looking at asthma and waist circumference, it would also be, you'd be able to compare that and tie that to other chronic disease outcomes. And there are other like fancier, more expensive methods like DEXA or CT-MRI, which is really the gold standard. But in terms of anthropometry, so the things that we can measure about adiposity, think waist circumference and then BMI are pretty solid things to use.
And WHR in this slide stands
Oh, sorry,
for,
that's waist to hip ratio.
I was wondering about that.
Yeah.
So is there a utility of us also measuring the condition, the waist circumference, the hip hip size?
So again, probably I don't want, to be the one opining on this, I'm not an expert, but it has not been shown to be superior to waist circumference in terms of predicting disease outcomes. So if you had to subject the patients to one of these things, I think the data would favor the waist circumference over the waist to hip ratio.
Great. Okay. Well, this has really been a wonderful talk. You're doing exciting work, and this is, I think, taught us a lot, and really appreciate it, Dinah. I want to remind everybody that if you want to get CME credit, please write to my assistant, BWH Israel Assistant, ASST, at partners.org, and remind you that in September, we're going to have an exciting talk on genetics and asthma by Quan Lu, and we look forward to seeing all of you again there. And wish all of you a enjoyable and productive summer. Take care.
Thanks
Thanks
again.
again, Dinah.
Bye.
Bye-bye.